Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. I'm your host, Dr. Kevin Hopkins, a family medicine physician and a senior physician advisor here at the AMA. 73%, that's the percentage of family physicians who are considered to be working in an employed model, contracted by a single specialty or primary care group, a health system or health insurer, or some other large organization. We know that choosing this type of employment often involves trade-offs, balancing autonomy, flexibility, and influence with predictability, security, and stability. By nature of our training, most of us were not taught how to practice our own well-being, especially in the context of being employed. To discuss how to be employed well, I'm joined by our guest, Dr. Mark Greenawald, family physician, professor, and vice chair of the Department of Family and Community Medicine at Carilion Clinic and the Virginia Tech Carilion School of Medicine in Roanoke, Virginia. Thank you for being here with us today, Dr. Greenawald.
Thank you, Dr. Hopkins. It is a pleasure to be here, and I'm greatly looking forward to the opportunity to having this dialogue with you around being employed well.
Oh, so am I. I know that we're all going to have a lot to learn and probably a lot to share as a result of our discussion. So, Mark, in 2022, you co-authored an article published in Family Practice Management, which is a publication of the American Academy of Family Physicians. And that article was titled, How to Be Employed Well, Optimizing Your Professional Satisfaction. In that article, you explore how being an employed physician and being well shouldn't be mutually exclusive. And you offer some tips on how to do both. But before we really dig into that, would you mind telling our listeners a little bit more about yourself and your background?
Sure. As you point out, I'm a family physician by training and have spent a lot of time both in medical education as well as in various capacities of physician leadership, including some time as our dean of students at the Virginia Tech Carilion School of Medicine, which was a medical school started in 2010, affiliated with Virginia Tech. Presently spend a lot of my time focusing on both well-being and leadership development. And in many ways, what we're going to be talking about today is at the intersection of those two things. We know that how one is led or the leadership structure that one works under has a huge influence in terms of one's own well-being. And that's some data that came out actually through the AMA and the work of Christine Sinsky. And so really looking at the challenge of saying, how can we begin to make headroads into the whole idea of physician well-being and physician burnout, to me, in many ways, comes through leadership. And in this case, looking at leadership through the employed lens of, by disclosure, I've been employed my whole career, starting with my residency where I was employed at the University of Virginia. Then I was employed by the United States military as a naval medical officer for 5 years. And since 1995 have been employed as part of Carilion Clinic, which is a integrated multi-specialty group here in Roanoke, Virginia, and the Southwest Virginia area.
Well, thank you, first of all, for your service to our country, and thank you for your service to your patients. I want to just make sure we level set. What do we mean by being an employed physician? That's different than having a job, right?
Sure. The difference is really in many respects on a simple scale where your paycheck comes from. You can think about that. You shared earlier that there are lots of different employment models that one can be part of, including the three that I've been involved with. One which is as part of an academic medical center, one is part of the United States government and the United States military, and then as a not-for-profit health system, a multi-specialty health system. There are lots of other ways that can happen as well. Certainly, as you point out, you can be part of a larger multi-specialty group in many structures. being part of a health insurer. There are now some people employed by health insurers. There are those who are employed now by venture capital, and that's becoming more and more of a prominent model, particularly for some of our subspecialty colleagues. But it really has a lot to do with where your paycheck comes from. So, to a certain degree, those who are even in private practice might be considered employed if they're not a partner in the group. So the group is then paying them for their work, and usually as part of employment, you get a salary and then some kind of performance incentive built in as part of that structure.
Okay, great. Thanks. That's helpful, I think, just to kind of give that background. And I mentioned in the intro that 73% of family physicians in the US are reported to be working in an employed model. Has there been a shift in that, like employed status, over the last several years or decades?
Absolutely. And we see that, first of all, in 2011, which is the earliest we have data from the American Academy of Family Physicians, it was estimated that about 60% of family physicians were employed. And so over the last 14 years, that's gone up by about almost 15%. And the statistic that's even more notable is during that time, the number of graduates who are going into their first job went from 80%. So even in 2011, 80% of new grads were already going into an employed model. That's up above almost 94% now in terms of the number of graduates in from the family medicine residencies who are choosing to go into some kind of employed status. What's also interesting about that, Kevin, is if you look at the larger data around all physicians and what's happening with them, the trend is very similar. That particularly since January 2019, the data that I was able to get access through is through January of 2022. So in those 3 years, which included, of course, COVID and the pandemic, the number of employed physicians across all specialties went from about 62% to about 74%. So our subspecialty colleagues in many ways are mirroring what's happening in primary care, and there's just been a delay in that process, and that's accelerating pretty quickly over the last few years.
What are the primary reasons, or maybe more accurately, the perceived benefits of being employed, and have those changed over time as we've seen this shift?
Yeah, depending on when your listeners trained, the initial impetus for employment when I went through my residency, going into private practice was still what we all aspired to because that was really the model that was available to us. What happened in the 1990s is that really with managed care, a lot of employment happened in order to leverage financially with insurers. So there was some consolidation because insurers started to become more aggressive about how they approached managing care, and really in many ways looking to cut costs or to become more efficient with care. Those motivations, however, have changed, even though still is some of that, certainly, because healthcare, as we know, is not getting any cheaper in general. And so there's a lot of interest in how we can make sure it is as efficient as possible. Some other motivations have really come more to play across, again, all specialties. First of all is just the opportunity for more regular work hours and a predictable salary. So not having so much uncertainty about one's salary. And then there's the whole idea of financial risk. When somebody in previous times, somebody would buy into a practice, so they would then be an owner of the practice, but there was a huge upfront cost to that. And as there became more and more medical school debt, the idea of then turning around and buying into a practice became more untenable for many graduates. So that less upfront financial risk, and then having the ability to be provided with the things that you need in terms of staff, in terms of management, call coverage for many became an issue, benefits packages, paying off loans, and the opportunity for loan repayment programs. Electronic health record really motivated a lot of folks because that was their opportunity to gain early access to electronic health records before they became more ubiquitous. Subspecialty networks and having an integrated subspecialty network is something that both you and I are quite familiar with in terms of the work that we do. And then just support for quality initiatives, care coordination, someone to manage staffing so that physicians didn't have to get into the HR aspect of care, and then a lot of administrative task assistance for things like prior authorizations, referrals, medication assistance, paperwork, form completion. All those things, when you look at the totality of those, they all became motivators in different emphasis for different physicians to decide that perhaps employment was a better option for them.
So all of those reasons make a lot of sense to me. I came out of medical school in 2002 and residency in 2005 as a family physician. And I remember having conversations with my friends and colleagues about, well, what are you going to do? How are you going to practice? And there was a lot of conversation around the expense of starting a practice, especially with the EHR. And I know you pointed that out, that was a barrier for a lot of people to really going into a private, independent practice model where they owned the practice themselves.
Yes, and our training was about a decade apart, and so that's really when the change, I think, started to happen. That was, you came into private practice post managed care, and that's when things were really starting to change. I think the beginning of that change. Again, we don't have a lot of data from back then, but I suspect that's when the curve started to become steeper in terms of more employment.
What are some of the trade-offs? When you choose a practice situation or environment, you're obviously choosing one model over another model. What might some people see as the trade-offs or potentially drawbacks to being in an employed model versus an independent, privately owned practice?
It's interesting, Kevin, just a data point that I found quite fascinating. This was actually out of some data that Medscape did. They had an employed physicians report in 2022, and they were basically looking at how one perceives employment versus being in independent practice, if you will, and kind of looking at how people assessed their work-life balance. And what they found was that the perception, there wasn't as much of a difference as one might have thought between the two. In general, those who were, quote, independent, assessed that they would have better well-being by being independent than by being employed. However, those who were employed, 44% of them estimated they would have better well-being being employed than being independent. And so the numbers weren't as, it was surprised me given what I had been hearing, particularly from my independent practice colleagues, of all the reasons why it was much more compelling to go into independent practice. But what does one lose by going into a more of an employed model? Well, a few words that come up that we may want to unpack a little bit more, particularly this first one, but there's a potential loss of autonomy, control. There's a potential loss for flexibility, and the perceived potential loss of influence are the ones that I think are the most frequently expressed by those who are thinking about making that move or even have made that move and providing on the other side some reflections on their experience. And that would include things like, when one is in more independent practice, you likely have more control over even things like your income. You can decide, if you work a whole lot harder, you will be able to benefit more from that directly. Whereas a lot of times in an employed situation, you have a contract model that will in some ways attenuate that potential in terms of particularly upside income. Or you also have the opportunity in an independent practice of saying, I'd like to earn a lot less and just work less. And it's easier to set up that structure than it would be in an employed model.
Okay. Yeah, we will come back to some of those words that you used, especially autonomy, because I want to ask you a specific question about that. Before we do that, let me ask you some specifics. Some of this you get into in the article from 2022 that I referenced, but you talk about part of being employed is being both organizational and being well. Can you tell me what it means to be organizational?
Sure. And Kevin, I think it's important to point out as we start this part of the conversation that we physicians may have learned, again, depending on when one trained, how to work on teams, particularly medical teams, and the emphasis of that has certainly increased over the last 2 decades. But we never really learned what it would be like to be part of a larger organizational structure and fitting into that. Even when I trained during my residency, yes, I was part of an organizational structure, but departments were much more independent, if you will, and autonomous than perhaps departments are now. And so the idea of how does my work contribute to something greater is part of being organizational. And that has to do with things like alignment. So once one is part of an organization, they are expected to be aligned with whatever goals, whatever values that organization has. There will be leadership structures that will likely be more sophisticated and more complex than would be in an independent type practice organization. There's the idea of citizenship. And now I am part of a structure or a community that will have certain expectations and standards that may be different even than the expectations and standards that I've been taught as part of my professional upbringing. So how do I then navigate through that? There's the idea of how value is calculated that may be different than the value that I see in terms of my independent interaction with a patient. How does that then fit in both economically, but also in terms of quality, in terms of resource allocation? How are those decisions made? And that becomes very different as there's more structure as part of our employment. And then finally, there's a different kind of emphasis on improvement. And particularly in terms of quality improvement, there's the idea of measurement that may look differently, and in some ways different emphasis. Particularly now, if an organization is part of ACO, there may be metrics that are expected that measure improvement that come from outside the organization, and having alignment around those for financial reasons as well as patient care reasons becomes a little bit different than it would be in an independent model.
I don't know that I'd ever really thought about it before in exactly the way that you articulated it, Mark, but the fact that we came out of training prepared to be a part of something larger, but really maybe just a group practice, not something a lot larger with a lot of people. I work for a health system now, large multi-specialty group with 77,000 employees. So I was not trained for that. I didn't have experience in that before coming here. And you mentioned being aligned. So, and I got to believe that has something to do with understanding your organization's mission, vision, and values, and what is my role in those things as a contributor to the mission, vision, and values of the organization. And I've heard people say increasingly over the last few years that maybe the values or priorities of the organization for which they work seem to be divergent from their own priorities and values, and that can cause a mismatch. Does that create strain and strife in an employed practice model?
Oh, absolutely. And that's where as myself and my co-author colleagues thought about this very issue, because we're experiencing it here, the same concerns that people had about, are we becoming too organizational? Are we becoming too administrative heavy and driven too much by perhaps the economics, and not really thinking, even though we talk about the patient care, there's the financial piece becomes more visible, and really asking ourselves, what does that look like, and what should that look like? And so I think part of that has been that we physicians have in some ways stepped outside of the conversation and given up some of our influence in the journey that health systems particularly, but others, have taken. So coming back then to saying, if that becomes something that there's a tension because we feel like the organizational values have drifted from our own, our answer to that was, okay, you have two options: either leave the organization, or how do you more effectively engage the organization in a dialogue around those values and priorities so that the physician voice becomes part of the conversation? And then again, that gets back to being organizational. How do you then come to some kind of conclusion about that works for everyone? And that means that for our administrative colleagues, understanding what it truly means to be patient-centric from the eyes of a clinician, and in this case, a physician, but from our physician colleagues, really understanding better what does it mean to be organizational and what kind of compromises may we need to make without compromising patient care necessarily, but maybe compromising some ways that we think things should be done, and understanding that sometimes as part of a bigger team, that's not always going to be the case, and how to navigate that then.
Working in a large health system, especially, there's so much to track, right? There's metrics, we measure everything, and it can be difficult to keep up with. What are the objectives and key results, or the most wanted improvements, or the key performance indicators, or however your organization gets organized around those. How can we really understand how our work is valued and how we do bring value to the organization? Is that something that we can tell based on like what the compensation model is? What would we look to identify, well, here are the things that matter most?
Yeah, and I think that there are many layers to it. It's a really important question. Thinking about, first of all, asking that question and really understanding from the very start. And I think this is step one, I think, of really becoming organizational, is as one enters into an organization, really understanding what is expected and what is valued, and making sure that in some ways that aligns with our values. Again, there are going to be some things that we may say, that's maybe not as important to me, but I understand why from an organizational perspective that would be important. And making sure that whatever we say would be our core values are not being violated in that process. So as you point out, compensation is one way, an important way that we may often estimate how we're valued. And certainly it makes a statement from an organizational perspective, how they value your work. But as you point out, that's not the only one. Productivity can be a way that an organizational values work. And certainly we are not alone here at Carilion Clinic in terms of understanding that patient access is a really important part of what we offer, particularly in my world of primary care. And so making sure that we are able to see patients in whatever context that we have our structure is set up to do, so that we're able to see patients. Value may be about innovation and about bringing new services or new products into an organization. Again, that's going to vary by the organization. Some organizations greatly value their brand. You work for one of them that you have an international reputation at the Cleveland Clinic, and so that brand and reputation brings value. So as you do good work, and as you do work with organizations like the AMA, with the backdrop of coming from the Cleveland Clinic, that brings good reputation and brand to your organization. Value-based care, of course, has brought a whole new realm of that in thinking about population health and how we do that. Organizations are going to value referral patterns and the downstream revenue that is produced in that process, depending on where one is in the structure. And then you get into things like cost savings, and how is that valued, and how does my work bring value by doing that? And many organizations, certainly ours, and I suspect yours, values how we as physicians and clinicians interface with the community. All those different ways go well beyond just compensation and productivity, and understanding that as one gets into an employed model can really be helpful in terms of making sure that there's not bitterness as those then values are lived out.
Yeah, all great points. And probably most people in an employed model, their compensation is derived from multiple sources like that. It's probably less common today for it to be strictly based on productivity. In my organization, we have an annual professional review, and they take into account things like your productivity and how busy you are, but then also your quality metrics, your patient satisfaction scores, outcomes, all of those things that really matter to our organization. Plus, then there's this general bucket of, I think you referred to it as organizational citizenship. And do you put a good face on the organization? Are you involved in things outside of just direct patient care? Are you on committees? Are you, how much are you involved in the well-being of maintaining the mission of the organization? And like you said, building the brand. So I think it's great for us to think about all of those possibilities. And we could spend a lot more time talking about this, but I want to talk about the other side of sort of this coin. We talked about being organizational. What about being well? What does that mean? Is it different? How is it different from being organizational? And how can we really match those two things together so that it's a mutually beneficial relationship for both the employed physician and the organization they work for?
Kevin, I like to think about a well-being continuum in general, kind of going from being burned out or distressed in some ways to being in survival mode. And then in the middle of that being fine being kind of just neutral, everything's okay, but not great, to being well, and then to be and then to be thriving. So burned out, surviving, fine, well, and thriving. And I think it's important, no matter what one's employment status, to begin to define for yourself, what does that look like for you? Because I don't think there's one way to be well. I think there are pathways to get to that, though, in terms of the structure of the work that you're doing. So defining for yourself. And then I would think the other part of that is understanding how the organization may define that. Does the organization think it's okay to work 100 hours a week? And that's fine, because we've had people who've done it before, and therefore we think that you can do it. Does that fit in with one's value structures? But then to start to say, what are some advantages of being employed that may actually enhance one's well-being? We talked earlier about the idea that being part of an organization brings you some structure that you may not have in private practice, and potentially brings some boundaries that you may not have otherwise, in terms of time off, call coverage, all those types of things. So those are things that can actually contribute to a lifestyle that's desirable for many physicians, to make sure they have time away from work to recover. So that becomes really important in terms of thinking about what well-being might look like within an organization. But again, also always coming back to the individual, and how does one define that for themselves becomes essential. And I worry sometimes that many of our colleagues really haven't defined well, okay, I'm not well right now, but what would it really take to be well besides retirement, which again sounds glamorous, but for many of us that's decades off, and so that's probably not a good answer.
Are there some specific points of frustration that are common to physicians in this area of defining and being well?
Yeah, and two of them come back to the words that we used earlier: autonomy and control. And that the idea that I feel like I've given up some power, and that disempowerment causes my well-being to decline. And so part of what we talked about as we created this paper, and really this paper came about because we were trying to, as leaders within our organization, try to come up with some answers for the questions that our own colleagues were asking and the concerns that they had. And a few of those things really come back to some important, I think, a few important areas of focus that become important in an organization to be well within that. The first one it has to do with employment and onboarding, and those who are employed understand that those are terms that are used that you don't hear as much about in the non-employed world. But how do we make sure that people start out well by understanding all the things that we've just talked about in terms of organizational values, organizational expectations? So from the very start, even before one signs the contract, they really understand what the expectations are, so they don't show up on day one and are immediately disappointed. So that becomes really important, is making sure you want to ask questions up front, I would contend, regardless of what employment status you're going into, but really as part of an organization becomes equally important. And then from the very start, becoming active. What we heard a lot from folks in terms of this mythical idea of being employed is, you provide me a salary, you provide me benefits, you provide me a management structure and employees, and then you leave me alone. And of course, that's unrealistic, and also an incredible setup for disappointment. And so taking an active approach to one's practice and saying, just because I'm employed doesn't mean that I'm going to sit back, that I would contend you have even more opportunity, first of all, for leadership. And I think more taking on leadership opportunities becomes even more important. So really taking from the very start, recognizing I'm a leader, and therefore, how am I going to help build the kind of culture within my practice that I want to work in that is in line with whatever the values are and the aspirations or goals of the organization. So, and then Kevin, when you think about financial well-being, really understanding how to what I call optimize your income. So not necessarily maximize your income, though that may be something you want to do, but to really be able to say, what kind of income do I want to have that also provides me the other things that I want in my life because I've defined what well-being looks like for me. So really understanding things like contract structure, benefits, and really what optimization would look like, and in some ways what the organization's goal for you is around some of those things becomes part of being well. And then improvement, I think, is part of that as well. That I think part of our well-being as physicians is having meaning in our work. And so as one really looks to say, how can I measure that I'm actually providing good care? Not just, I have a good and kind feeling that I'm providing good care and I'm enthusiastic about it, but what are some objective measures that I can use and the organization may think are important that can help me feel like I'm actually providing good care to my patients? So being about that from the very start, I think can enhance our well-being as well as the organization's well-being at the same time. What I've learned about autonomy, if you look at the dictionary definition of autonomy, it's self-governance is the first definition. And one can pause and step back from that and say, really, unless I'm in independent practice all by myself and take cash only, I'm really not self-governing. And even then, I have my patients who become kind of my board of directors in terms of influencing my priorities within the practice. So arguably, are any of us really autonomous? But even getting past that, autonomy is not a black and white issue. There are degrees of autonomy that we might have within an organization or outside of an organization. Again, if you're in a large group practice, but it's an independent practice, you still have a governance structure. You still have those who are the owners and those who are the employed parts of that structure. So thinking about when you're employed, how can you get back some autonomy and get that back? And I contend that one does that by getting involved and doing the things that we've just talked about focusing on quality, about looking for opportunities for improvement, communicating effectively about those things, creating a culture of feedback, not only where I'm giving a lot of feedback about my opinions, but I'm open to feedback and growing out of that feedback. And if you will, being, quote, part of the solution, rather than always just bringing up the problems. And my experience has been as physicians do that, they actually gain autonomy. And the organization gives them more leverage to become more creative, to try new things because they realize that they want to be part of the system and they've in some ways bought into the system's goals and mission.
I want to go briefly back now. I mentioned I would bring this up again, but we've used the word autonomy. What does autonomy mean, especially in the context of the practice of medicine in 2024 and beyond?
Yeah, it's a great question, Kevin, and an important one because it is something that we hear a lot in terms of just the literature in general, and many people use that as the compelling reason why someone should stay independent in terms of this sense of losing autonomy. So what I like to think about autonomy is degrees of autonomy. And so you can go from complete self-governance to total lack of autonomy. And most of us are living in between there. So we're using the word autonomy, but we do have some autonomy, just not necessarily as much autonomy as we think we should have. And that becomes, I think, the sticking point is it's not about whether or not one has autonomy, but it's about the degree of autonomy. And even in an independent practice model, let's say a privately owned single group practice, you're still going to have a leader of that practice. You're still going to have partners most likely in that practice, and then a group of partners who are, or a group of workers who are not employed that are aspiring perhaps to become a partner or need to buy in to become a partner. So I think we really owe it to each other as a physician community to really talk about that term and become honest about what it is that we're really meaning and what it would take then to be in an employed status and have more autonomy than perhaps we have now.
Yeah, that's super helpful. And I think there's probably even some specific domains in which physicians mean that autonomy. Any other pearls of wisdom you want to share with our audience, Mark? Anything that you didn't get to share in our conversation today?
Kevin, this has been a rich conversation, and I would love for this to stimulate a dialogue around how we as physicians can advance this process and allow ourselves to become even more effective in terms of being organizational. We know that the trend for being employed, while it may vacillate, it's likely not going to change anytime soon. And maybe we've reached a plateau, maybe not. It depends on a lot of forces that are sometimes some within and some beyond the control of physicians. But the fact is that in your and my career, certainly the majority of us are going to be employed. And so learning how to do this well, I think becomes essential for not just our career success, but also for our professional and personal well-being. And so I think it's a worthwhile investment for folks to really give this some consideration and perhaps talk amongst themselves within their organization about how they can do this better.
Well, I couldn't agree with you more, Mark. When I first read this 2022 article, I, of course, read it through the lens and from the perspective of an individual practicing physician. But then I thought about it and I thought, this is actually really good for health system leaders, too. If you want to know what matters to physicians, what matters most, and what helps us to feel valued, you wrote a lot about it here. So thank you. Dr. Mark Greenawald from Carilion Clinic and the Virginia Tech Carilion School of Medicine has been our guest today. AMA Steps Forward has many resources to support you on your journey toward professional satisfaction, including the Wellness-Centered Leadership Playbook and what to look for in your first or next practice toolkit. Check out the episode description for more resources, and until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.